afternoon, everyone. I'm Robert Spouse. I am with Telehealth Rocks. I really want to appreciate everyone being here today. I know last summer we offered a couple echoes during June, and actually last year into July, but this year we'll only go into June for focused on schools and communities. And weren't really sure how these very intensive echoes would go, where they're 3 or 4 weeks in a row, and the sessions are an hour and a half. We had really great representation last summer and participation in our echoes on psychological first aid and on skills for psychological recovery. And this echo actually makes the third part of that series. We were funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, with the disaster response grant, focused on schools and communities, on school-aged children, and really wanted to talk about all three components, moving from really immediate post-disaster, just responding through psychological first aid and in a way to meet needs right in front of us, and then moving into skills for psychological recovery as we moved post-disaster or post-event, traumatic event. And this is the third component, where we'll look at some more intensive approaches, as well as really taking an examination of when children may benefit from trauma-focused cognitive behavioral therapy. This is designed for more of a general audience as we think about this and we think about student and community needs. As we get started today, just wanted to provide a couple notes. This is being recorded, and we'll share it with you afterwards. Your microphones have been muted. Please feel free to unmute and ask questions, or you can use the chat. We love having lots of conversation. We'll have a chance today when we go into breakout rooms for you to practice some of the techniques you learn. We will be sending out the completion certificates after the series ends. So it's important that you make sure your first and last name are of what's listed with your name. You can click on the 3 dots on your Zoom screen if your full name isn't visible and change your name, use that choice. So I'd like to introduce our speakers for the session today. We have Erin Hambrick, excuse me, I know her name, how to say it, I'm just not talking well today, who is a clinical child psychologist. Melissa Maris, I can't say anyone's name, they're all gonna yell at me afterwards, who is a clinical community psychologist, and Joe Williams, who is a clinical psychologist as well. Now I'm gonna hand things off to Erin to start today's discussion. Thank you so much for being here. We're so excited to have you.
Yes, thank you, Robert. And we won't yell at you because that wouldn't be very trauma informed. So we're gonna accept and so we'll start off here. I'm Erin Hambrick. We'll start off here with our usual disclosure slide. We don't have anything to disclose, and our goal today is to provide you with best available evidence, and we will be linking you to many, many resources developed by teams from all over the US throughout the time together today. Next slide. So first, I want to provide a brief overview of the 3-part series that we're going to be doing this summer. Today, we're going to be focusing on which children need trauma-focused approaches at that tier 3 level. And Dr. Maris is going to orient us within that tiered systems of support here in a minute. But this time we're really focusing on tier 3, and also how do we even get the ball rolling in terms of connecting youth to available and relevant services. And particularly, how do we go about this identification and referral process in the most trauma-informed or sensitive or responsive way? Next time we meet, which will be a week from today, we're going to focus on what you might expect from a trauma-responsive mental health provider. We'll talk about a variety of resources that they might draw upon. And we'll also talk about how to kind of learn the language between schools and mental health providers so that we can be speaking together about children even better than we are now. And then session 3, we're really going to focus on an introduction to trauma-focused CBT, what it is, how you can become officially trained in it, how you can find resources, and also how, if you're working with a child within a school setting, who is receiving an intervention like trauma-focused CBT, how you can be supporting that child within the school setting. So again, how can we all be getting together and actually having the same goals in supporting kids instead of having different goals within the school than we do within community mental health centers or other systems that children and families might find themselves involved with. Next slide. And then we'll give an overview for today. So we do have 90 minutes of time together. The first hour will be a didactic presentation that will be split up between myself and Dr. Williams and Dr. Maris. We will pepper in some chair yoga exercises so that you all can begin, just learning some additional tools to use, but also so that we can keep ourselves focused and grounded and really present in the time we spend together today. During the last 30 minutes, we're going to do just kind of a breakout room scenario where we will talk through a situation and how to respond to that situation in ways that are congruent with principles of trauma-informed care. And then we're going to attempt to end with plenty of time so that we can have a short question and answer. Next slide, please. So many of you who've done a lot of these trainings know that we like to use word clouds, and this time we actually did the word cloud in advance. Thank you so much to each of you who took the time to fill out the registration survey and the pre-survey. It really does help us know our audience and tailor these trainings in ways that we hope will be useful for you. And I think it was in the registration survey where we asked, what do you hope to learn from a session like this? We have our idea about what we're trying to accomplish, but how can we help that meet your all's needs? And so we kind of popped in some of the really frequent words that we identified as part of that survey. And something that stands out to me more than anything else is that people are really hungry for specific tools and strategies that they can use now. And so we are really trying to pepper that in and focus on that as much as we can. People want to know best practices. People, it seems like people want to know, if I'm doing something, how do I know if it's appropriate? How do I know if it's trauma informed? And hopefully we will begin to clarify that through this training series. How do I help? How do I improve skills? How do I engage students and support teachers? And of course, we absolutely can't hit on all of this, but we're gonna try to do what we can. And I think another takeaway that I have from this slide is just how engaged each of you are in the settings in which you work. And this is really a group of very motivated individuals. And I hope that beyond just, working with us as presenters, that you'll look around, who's here? What are the names that you see in the Zoom? Do you remember any of them from last summer? I know I certainly do. And hopefully this can be a good mechanism of networking for you as well. Next slide. So, sorry, I'm pulling something up here on my other computer, but we want to make sure here at this time that we don't miss an opportunity to recognize really explicitly the recent mass tragedies that have happened in the US, and particularly the school-based tragedy in Uvalde. We don't plan to process these groups in detail, or these events in detail as a group, because we know that, some research would suggest that's not all that helpful, and people have different preferences related to how much they want to be exposed to that content. But we do want to offer for you, please feel free while I'm speaking to direct message Dr. Maris or Dr. Williams. They've both said if people want to kind of direct message for support or for ideas for support or advocacy, that they're very open to that. I'm open to that as well when I'm not speaking. Now during this session or at a later time, I know Dr. Williams has a lot of resources ready to share. But we do want to acknowledge that these events are heartbreaking and that we're all struggling with how to deal with them. And so we encourage you to use the resources and strategies that we've talked about here and that we've talked about last summer for yourself. Reducing consumption of excess media, reaching out to family members, friends, coworkers, experts, mental health experts for support. We deserve those services as well. And, be mindful of your stress level and how it affects your day-to-day functioning and how it might be changed in response and in reaction to hearing about these types of events. Some of you might be here today as a way to say, I care about these events and I want to be part of the solution. And I know that a lot of people find meaning in that sort of engagement and advocacy. So with that said, we're going to move on to our first activity, which is just a very simple chair yoga activity. We're going to pepper these in throughout the trainings. And the reason that we're going to do this, I mentioned before, is kind of twofold. One is that these are strategies that if you work in classrooms or if you do therapy in group settings that you can use. You can hear me do these and then take them and use them. I just completed a certification in school-based mindfulness and yoga strategies, and I hope to share that with others so that they will use it. But also to serve as a reminder that as providers, as helpers, as teachers, building these mindfulness-based activities in throughout our day is very trauma informed. The more regulated and present that we are, the more likely we are to have the capacity to work and engage in ways that are trauma informed. When we are present, we have more opportunity to choose our response. And that's going to be a big focus of this 3-part training. So for just a moment, find a comfortable seat in your chair. Maybe you'll cross your ankles, maybe you'll cross your legs, whatever makes you feel settled into the chair. And for just a moment, reflect on what your energy level is right now. Is it low? It's right after lunch. It can be a low energy time of day for a lot of us. Is it high? Maybe you've been really busy and your day is scattered so far. Whatever it is, just take a moment to notice it. And also notice how your body feels at that level of energy. If you're at a high level of energy, does your body kind of feel tense or tight? A low level of energy, does it feel heavy? How does your body feel at this level of energy? And now we'll just move forward with an awareness of that energy level, an awareness of where we are in our bodies and where we are in our day, so that we can move forward more mindfully into the content. Next slide, please. All right, and with that, I'm going to go ahead and pass it over to Dr. Maris, who is going to do the first part of our didactic.
Hi, everyone, and good afternoon. It really is a privilege to be here with you all today. And so these first few slides are pretty big pictures. Just wanted to run through some common terminology so that we can all be trying to kind of speak the same language. I was watching the introductions in the chat as folks were joining, and just want to recognize that we have a number of friends with us today who are joining us from schools, or might be working with organizations outside of schools, but working in schools, working outside of organizations or outside of schools and other kinds of organizations. But one thing that we do very well in education and in behavioral health is use a lot of words and use a lot of acronyms. So just kind of wanted to unpack this so that we can make sure that we're all kind of on the same page. So many of you have probably heard of this term or used this term, multi-tier systems of support, or MTSS. And so this is essentially the public health model applied typically in education. MTSS is very commonly used in terms of federal resources, many state resources. It might be something that you all are using in your schools or the schools you work with. But essentially, the basics of a public health model is this idea that we have different levels of support. Sometimes they're called tiers. And the idea that at our basic sort of fundamental level, we have universal supports that all students receive. And so in many ways, if you think about a public education, this is going to be the standard sort of classroom curriculum, the free and public education that all young people receive. That would be universal education supports. And we know that many students will benefit from and kind of maximize their potential with those universal supports. That's why we start with those foundational kinds of resources and interventions. But we also know that some of our young friends will need additional supports, and that's kind of how we then shift to a more intensive level of supports, sometimes called Tier 2. And these are either young people who either are not benefiting fully from the universal supports that are offered to all young people, or young people who have some additional kind of risk factors or a lack of resources that they're bringing to the table. And so then we shift in kind of to this middle yellow level with some additional supports often delivered in the form of group kinds of interventions. So if you think of sort of on the academic side of the house, in a third grade reading class, you'll have what everybody in the classroom gets, and then you might have some more intensive targeted groups that you pull students out of the classroom and do some more targeted interventions. And that in general, kind of with our universal and this next level of more intensive supports, this is going to serve most students. But we do know that some of our young friends are going to need even more intensive supports, and that's kind of when we continue up the triangle with the idea that as we go up the triangle, our resources are becoming more intense. These resources typically take more time and more money, and just in general are more intense, more frequent. And these are the young people who are not benefiting from either what's offered universally or at this next level and really need the most intense resources. Throughout the entire kind of system of support, there's ongoing parent and family communication, collaborative problem solving, and I'll talk here in a second about kind of some common elements of these kinds of models. So terminology and just some acronyms that you may have heard that are absolutely associated with multi-tiered systems of support. Certainly positive behavior support, so PBS, PBIS, SWPBIS. Some states like to throw in their letters in front of that, so Kansas PBIS or Missouri school-wide PBIS. Response to intervention, which is often associated with the academic components, similar kind of approach with this tiered model, so RTI. But I've certainly worked with schools who use PBS or RTI and then toss academic or behavior in front of it. So behavior RTI or academic PBIS, again, it's the same basic model, but then kind of the focus of the content, whether folks are putting it in the behavioral or the academic. Sometimes you'll see social emotional learning, PBS or RTI. The interconnected systems framework. So if you are in a school or working with a school that's done a lot of positive behavior supports, you might be familiar with the interconnected systems framework, very much built on this idea of these multi-tier public health models, but really trying to pull together the behavioral kind of PBIS, typically that foundation, with some other integrated mental health supports. Some folks will call these the pyramid or the triangle model. This kind of triangle with these colors is very familiar probably to our friends who are working in schools or with schools. Increasingly, we're seeing folks use MTSS, the acronym, and then talking about an umbrella of supports. And so sometimes this is depicted as an umbrella, where then folks put the different models and frameworks that they're using underneath that kind of all-inclusive sort of image. And there's also terminology used for the different levels of intervention. So often tier 1, tier 2, tier 3. Sometimes there are additional tiers. So people add tier 4 or tier 5. Sometimes people associate them with colors. So green, yellow, red is probably the most common. But again, folks use different colors for different levels, and that, again, intensity of intervention. And then also talking about universals, either select or targeted or intensive. But again, I think the critical piece here is that it is actually all related. It's all the public health model and this general idea that we will be most effective if we focus first on providing good, effective practices and support for all students, and then kind of go from there in a way that is systematic. We can go to the next slide, please, Christy. So in terms of MTSS in practice, there are some commonalities across all of these models and frameworks. I think there is absolutely unique value add for each in this conversation, but for the purpose of our conversation today, commonalities are that they are systems of support. And so what that means is that it's not just one intervention or one practice or one policy or one program. It's a system. It has lots of different parts. And I would argue that as a system, it's also dynamic. So it's changing. It has the potential to expand to include additional supports, and that it's always in flux in the sense that we're hopefully always using good data as part of teams to make decisions about what's making sense and what works for kids. So that data-based decision making, that it is systematic. And so there are routines and processes in place, kind of that infrastructure in place to determine who gets how much of what. And again, relying on data so that we're utilizing our resources well, and that we're really looking at those routines and processes as a way that we can serve as many young people as possible with the best possible resources that are going to help them be successful. That's why we have the forms and the data collection, timetables and things like that, is so that we can feed information into these systems and try to make the best decisions possible. That it is absolutely collaborative, that this is something that is whole school, whole community kind of approach, that everyone has a way that they can access this information and the system, the resources, including parents, guardians, and families, and absolutely including young people themselves. So we want to make sure that we're being inclusive of all disciplines and all professionals, and absolutely that this does expand into the community. So we are not talking about insulated systems within schools, that we're recognizing that schools are necessarily part of our communities. And so that we have to be considering community resources as well as community needs and assets along with that conversation. That within these systems of support, that they are layers of support with increasing intensity for fewer young people, right? So as we go into more intense supports, they're intended to be provided for the young people who have the greatest needs. And also this idea of layers. And so even though we look at that triangle and we see kind of this first tier and then second tier and third tier, really the way to picture it is that the entire triangle is green. And then on top of that is another smaller triangle that is yellow and another triangle that's red, with the idea that even if a young person needs additional supports, it doesn't mean that we take away any other supports. If a young person needs additional help learning how to read, it doesn't mean that we remove them from the classroom. They're still in the classroom and they benefit from that universal or whole school, whole classroom approach, but then also need some additional supports. It's important to acknowledge that tiers or levels or different kinds of supports are supports. They are not children. And so we don't talk about tier 1 kids, tier 2 kids, tier 3 kids. Young people are not walking around schools with little hats on that are red or yellow or green. These are layers of supports and interventions, not children themselves. And that absolutely, when we think about use of the public health model in any space, that we have to make sure that we're remembering it's defined by context and population. So a good example here is that you can take the public health model and apply it to a school. You can also apply it to a district or a community. Similarly, our friends who work with young people with developmental disabilities absolutely take the public health model and apply it in a smaller population with a different set of needs and assets, right? You can still use the same idea. It's just dependent upon the population and context that we're using it in. So some tips and tricks is one, find yourself and your work. So if you are in your school, if you're working with folks outside of your school in the community, if you are outside of a school and working with a school, working with other schools, is just multiple times just to kind of, in a mindful way, kind of check in and make sure you know where you are and where other people are in terms of what you're actually talking about. And I know it sounds basic, but this is something I have to remind myself to do constantly. And just making sure that we're using the same language. When we're talking about different levels or layers of interventions that are more intensive, kind of reminding myself, oh, okay, so right now we're talking about kind of these tier 2 kinds of supports that are not for all kids, but not for the young people who have the most intense needs, but we're kind of in the middle. Know your shape. And so with that, what I mean is kind of public health model. If you're on a circle, that's great too, but just kind of knowing again, how what you're doing connects to the broader system, and kind of where you are and what you're doing, and the young people that you're working with in terms of the support you're providing. Learn your acronyms. So write them down. Kind of create dictionaries. This is work that I've done with collaboratives that are working across education, schools, mental health, and other groups. Just creating kind of a dictionary to reference can be really powerful. And also just kind of doing the work to establish and enforce norms. There's nothing worse than being a part of a team where you're talking about something and then you realize that everyone else around you actually knows what's happening and you're not sure that you do because you misunderstood an acronym, right? And oftentimes we don't ask for clarification, even if we know we should, because we think that maybe we should know. And the reality is that there's just a lot of acronyms, there's a lot of letters. And so asking for clarification, but also just being mindful of other friends who are in the room who may not actually know kind of these different acronyms that are very specifically defined. Talked about this before, but it's important to talk about supports and not people in terms of navigating the public health model. Invest in being systematic. And so this is really where, the most effective multi-tiered systems of support that I have ever experienced and seen are very, very systematic. So they write down routines, they have processes. It is very structured. And again, remembering that the reason that we value being structured in these systems of support is because it does allow us to maximize our use of resources for as many young people as possible. And just to use it dynamically. And so you might be someone who is very familiar with the public health model and kind of all the different ways it can be used. But we all can benefit from practicing and kind of applying this in different situations, right? So in this webinar right now, in this conversation, we can apply the public health model to everyone who is here. We all have a shared common understanding of some things. Some of us need a little bit more support to kind of catch up and to be on the same page. And some of us need a lot more help to really understand what's happening and to benefit from the conversation. And that's an exact application of the public health model even to this conversation. So using it dynamically to make sure that it really makes sense in your work. We can go to the next slide, Christy, please. So MTSS and trauma. Along with all of the school-based frameworks and the use of the public health model, kind of the evolution of multi-tiered systems of support in schools and looking at community involvement, there is work and ongoing work to connect trauma to this conversation. So this is one example out of the American Institutes for Research. There are others. The Interconnected Systems Framework, again, is one that is being used a lot right now to connect school mental health and different kinds of supports and trauma to kind of this public health model approach. And with this idea, again, we see our triangle, we see the different levels of intense interventions, increasing intensity, and then looking at it specifically for trauma. So when we're talking about trauma and a public health model in schools, at that tier 1 kind of universal level, we're looking at what all young people and all adults in the school get or receive, kind of that foundational knowledge. This is going to be any of your trauma-informed schools practices, and I use that broadly. So any of these trauma-sensitive, trauma-aware, this kind of foundational base of information, clear expectations, routines, schedules. That's an example of a universal trauma-informed approach. And also psychological first aid. So we talked about psychological first aid last summer, but psychological first aid really is intended to be a universal tool that can be used in all kinds of different contexts, but is important kind of as a base knowledge for folks to have if they need it, when they need it, in terms of kind of how they can respond and support young people in the direct aftermath of a natural disaster or other kind of event. And we know that that tier 1, those universals, are going to be super helpful for a whole lot of kids. And that's going to be all that a lot of kids need. But some young people need more. And that's kind of when we move up to that secondary level, that tier 2. And that's where we're looking at skills for psychological recovery. So typically SPR is used a little bit further after an event happens, and kind of the universals have been put in place, and we're starting to identify young people who might need some additional supports. And that's where something like SPR might be helpful. We know that as a safety net, that's going to catch a whole lot more young people, and that's going to be enough, and that's going to support them and their ongoing well-being. But that some young people need more. And that's really where we're getting up to that top most intense level, kind of where we're looking at trauma-focused CBT, where we're seeing behaviors or know of existing trauma. And these are the young people who need the most intensive supports. So again, kind of thinking about least intensive to more intensive, all kids to fewer kids, and that trauma, just like academics, behavior, social emotional learning, health, anything really can be put on that public health model. And that our series here is really focusing on that very top tier of young people who need the most intensive supports around trauma. So with that, Joa, I think it is going to you.
All right, pass that along. Thank you. Thank you for the intro and for kind of giving us that overview and just to sort of, I guess, echo what Dr. Maris said there and thinking about this tiered model. I think one of the things that's really important to note about a tiered model of care here is that we're really starting to see, I think, greater recognition across multiple systems, right? Whether we're talking about school systems, whether we're talking about healthcare systems or any other different number of systems where folks are often coming in and can receive support for trauma and other kinds of experiences, negative experiences and mental health concerns. There's greater recognition that we have to have this kind of tiered approach if we really want to expand care to folks, right? And so we're starting to see this tiered model adapted, used and adopted in a number of different systems, a number of different settings. But one of the things that I think is important to also note, in thinking about just how we've seen these models adopted, at least in healthcare systems, for example, and I think this is true also in school systems, right? To really be, to take a public health approach to addressing trauma and making sure that we get effective treatments, preventive treatments where we can, treatments for folks who are going to go on and have more chronic kinds of reactions. It's really going to take a lot of resources and a lot of folks who have some basic understanding of a lot of things that we really want to be looking for to help make sure that folks are connected to the resources that they need, right? So I think that when we think about the importance of what we're doing here today and the webinar that we're, the echo that we're doing here today, all that you can take away from all this, right? We're really helping, I think, expand awareness of a lot of the issues that affect many of the kids and families that we work with. And through that improved awareness, we can start to, I think, really help put this public health kind of model into action. So I just want to, again, express my appreciation for all of you being here today. I think it takes a lot of folks with a lot of heart and a lot of commitment to make this work happen, to really make sure that we're providing as many resources as we can to trauma exposed youth and families. So I just want to echo what everybody else said. Thank you all for being here today. So when we think about how to integrate these tiered systems, right, into the systems that you're a part of, right, or these tiered models into the systems that you're a part of, let's just start by sort of thinking about what is a basic definition of trauma, right? We talked about this some in the ECHO series that we did last year on psychological first aid and skills for psychological recovery that I imagine some of you attended and might remember. But I think it's always helpful just to kind of have an orienting definition that we can use, because really when we look at these tiered models of care for trauma and trauma exposed youth and families, right, it all starts with sort of the experience of trauma. And what do we mean by that? Well, SAMHSA, which is the Substance Abuse and Mental Health Service Administration, defines trauma sort of using the 3 E's is what they call it, right? So they offer what they call the 3 E's of trauma as being core to understanding what it is we mean when we talk about traumatic experiences. So really, when we are talking about trauma, and this is also consistent with how the American Psychological Association and American Psychiatric Association defines it, we're talking about events, right? Discrete events, or often discrete events, something that occurs as a discrete event that somebody experiences that involves extreme stress, although these events can also involve a set of ongoing circumstances, right? Sometimes these events aren't necessarily discrete events with a clear beginning and end. Sometimes they involve a series of ongoing circumstances that still contribute to or cause undue and unnecessary stress on an individual, on a family, or on an entire community even. So really, we're talking about events or a series of events that then are experienced. They're experienced by someone, right? These events happen, but they are experienced by someone as being physically or emotionally harmful or life-threatening, right? So that's a key part of the definition, and that, at least in SAMHSA's definition. And that also maps really, really well onto what the American Psychiatric Association sort of defines as trauma, right? Where they sort of talk about, we have these different discrete events or series of events that often involve sort of specific reactions like fear or helplessness or horror or any number of other kinds of emotional responses that people might have to extreme stress. One of the things that I do want to just, add that I think APA actually gets right, that's not specifically mentioned in SAMHSA's definition, as far as the experience goes, right? SAMHSA says that the experience is something that's experienced by an individual as physically or emotionally harmful or life-threatening. But I think it's important to note too that sometimes we may not necessarily perceive harm to ourselves. Our own life might not have been in danger, but we might witness someone else having been harmed, or we might witness someone else having had their life threatened, or even having lost their life, right? And so in those kinds of circumstances, even if we weren't directly involved in a traumatic event, witnessing trauma under certain circumstances or witnessing certain kinds of events that produce those reactions in other people can still be traumatic for us, right? And so I think trauma has that kind of ripple effect, right? The experience can ripple across entire families and entire communities, right? And that ripple effect kind of leads to the third E that SAMHSA talks about, which are the effects, right? Trauma has lasting effects on individuals, on families, and on communities. And so the effects that SAMHSA specifically kind of talks about are effects on a person's functioning, right? How well am I doing at school? How well am I doing in my social functioning? How well am I doing at work, right? How well am I doing just at home with my family and in my interpersonal relationships with people? And then well-being, right? So what are the effects on mental well-being, on physical well-being, social well-being, emotional well-being, spiritual well-being, right? So those are all important for us to consider, because I think that those lasting effects, again, when combined with a person's subjective experience of specific events, are really what we want to think about when we think about what makes something traumatic, right? And so we could easily imagine the number of different kinds of experiences that produce extreme stress, right? Or the number of ongoing circumstances that produce extreme stress that are experienced by folks that produce these kinds of lasting effects. We're really talking about a lot of different kinds of events, right? And when I ended by talking about just the range of effects involving social functioning, right? Mental well-being, physical well-being, emotional and spiritual well-being, I think more often than not, in the work that I've done, at least, and in the literature that I've seen in this area that's continuing to come out, it's more common than not, right? That folks are going to have different facets of their lives affected, right, across a number of those different areas, right? So physical functioning might be affected, social functioning might be affected, emotional functioning might be affected, all in the same person and in the same individual. And when we think about kiddos in particular, right, if physical functioning is affected, if mental or cognitive functioning is affected, if social and emotional functioning is affected, right, that's going to affect your ability to really go to school, to learn, to be part of your community in your classroom, right? And that's going to have some important effects. And so I think that just understanding how these kinds of tiered models can really help change that, right, for folks is really what we're talking about here. But it takes all of us, and it's going to take a lot of us working together to really provide all the adequate resources that we need to help try to catch those kiddos early. And so that kind of goes down to, I think, what Dr. Maris was saying and talking about these multi-tiered systems, right? when we think about what's the benefit of doing that, right? Benefits of these multi-tiered systems or interconnected systems. So here it says benefits of ISF on the slide. That's just another acronym for talking about interconnected systems, right? These multi-tiered systems. The real benefit of doing that, when we can do that, the more we all learn about what to look for, how to connect kiddos to resources they need and get those things to them in a timely way, is that these models can really help uncover students with mental health needs related to trauma a lot earlier. With earlier detection, we can help connect folks to resources more quickly, and it can minimize a lot of unnecessary suffering and really help, I think, improve outcomes much more quickly, right? And it also helps us link students with ongoing trauma-related concerns, right? Mental health concerns in particular, to some of those evidence-based interventions that they might need to help promote recovery, right? And we're actively talking about using data at the individual level. How's this kiddo doing? And we can kind of determine what level of care they need, but we can also start to see impacts from their recovery on entire systems. And so I think that's one of the things that's really nice about using these kinds of models, right? With each child and for every child and family that we help put on a path towards recovery, we're also helping entire classrooms, entire communities begin to recover too. And hopefully we start to see that impact. And I think it involves expanded roles for clinicians, but it involves expanded roles for all of us, right? And in doing that, hopefully we create healthier school environments. So I think there's a lot of benefits to really using these kinds of multi-tiered, interconnected systems kinds of models. But to put this into practice, we need to go in with a few sort of broad principles in mind, right? What are some general sort of principles or ideas that we can apply both in our individual work with kiddos and families, that we can apply when you're in a classroom, that we can apply in clinical settings, right? What are just some basic principles that we need to keep in mind to put into place or to implement a multi-tiered system specifically for the care of trauma and trauma-related conditions, right? So if we go to the next slide, then let's think about some big principles for trauma-informed care and sort of how we can begin to think about these in the work that we do on a one-on-one basis with folks, or even at the level of entire systems. And so SAMHSA, in addition to talking about the 3 E's of trauma, also gives a sort of basic overview of 6 principles that they say are essential for trauma-informed care. And the 6 principles that they talk about as being essential for trauma-informed care, and I'm just going to quickly go through all of these real quick before kind of speaking to each one individually, are safety, trustworthiness, and transparency, peer support, collaboration, mutuality, empowerment, voice, and choice, and then cultural, historical, and gender issues. Now, I want to just briefly start with, or not necessarily briefly, but I don't know that we have enough time to go through all of these in as much detail as I would like, but I want to start with this last one here, cultural, historical, and gender issues, because I've actually heard some interesting discussion around this that I think is important to consider, right? The inclusion of that specific element as a principle has actually been critiqued by a number of folks, right? Specifically because it assumes that that's a principle that exists alongside each of these other ones, when in reality, I don't think we can provide safety. I don't think we can provide trustworthiness. I don't think we can be collaborative, and I don't think we can empower people if we're not sensitive to cultural, historical, and gender issues. So in some ways, thinking about that as a separate principle may not be the best approach for us, right? It's something that has to sort of, I think, encompass all of these other principles, and we have to take that approach in viewing how we implement each of these other principles if we truly want to be trauma informed. So if we start from the basis of assuming that all of our work in building any tiered model has to involve careful attention to cultural, historical, and gender related issues, what does that mean, right? Actively moving past stereotypes and biases and offering inclusive services. So that means that I think individually, we all have a responsibility to be mindful of and aware of our own biases, what that means, what that looks like, right? And then we also have to be mindful of the biases that are in our system and work to dismantle those when we're aware of them, right? If we're not actively doing anti-racist work personally or in the classroom, how are students who've historically been targeted for oppression going to feel safe? So I think that we have to keep those basic principles, or that basic idea at least, in mind before we can begin to implement other principles. And let's just start with safety, right? So when we think about a principle of safety, ensuring physical and emotional safety is going to be key when we try to implement any kind of tiered model that provides a number of different levels of support for trauma survivors in a broader system like a school system, right? So when we think about safety, how can we actually make sure that we create physical spaces, right, for folks to feel safe? How can we approach people in ways that helps them feel safe? And how do we ensure that? So I think that's something that'll be important for us to consider. And when we go through our breakout activity later on today, we're going to think about just even things that you can say, right? When you're talking to someone or talking to a young person who's and you're not sure what's going on, but if you were to consider safety and consider how to have those discussions with kiddos about potentially sensitive topics in a trauma-informed way, what would you do and what would that look like? So that's one thing that I think is important for us to consider, is to think about what safety means, how we can use ourselves, how we can create physical spaces for that. Trustworthiness, right? Within organizations, we have to make sure that decisions are made with transparency, right? With the goal of building and maintaining trust for all. Okay, so within school systems, right, if we think about what that might look like, what might it mean to build trustworthiness if we were to think about implementing a tiered model, right? That's something that I'll challenge all of you to kind of think about what that might mean. But how can we actively engage and make sure that all stakeholders involved in a tiered system have a say, right? And know what everybody else is doing. I think that's really kind of the key of trustworthiness. Peer support, right? Using and utilizing stories and lived experiences from people to help promote healing. I think sometimes, especially if we're talking about working with older kids and youth, right, and adolescents, a number of trauma-specific interventions for older kiddos is going to involve groups with other folks who've gone through similar kinds of experiences, right? Working with your peers and making sure that peers are available to support you. I think that's one of the real value of having different kinds of groups where you can be with other kids similar to you and your age. And even for teachers, right? Educators, professionals, those of you that are working within these systems, how do you support each other? And what kind of peer supports do you have in place to support each other, right? I think we can always draw strength from one another, and that's really the basic idea of peer support. Collaboration and mutuality, right? We all have a role to play, and even by being here today and learning about how you can have a role in building these kinds of tiered models and think about what you can do within these tiered models, we're really thinking about collaboration together, and that's a really important thing. Empowerment, voice, and choice, right? We want to make sure that folks' strengths are recognized, built on, and validated. Okay, and so I think that really when we think about that, that means that we want to give folks choices where we can. That can be something really small that you do for someone, an individual in the classroom. That can mean that when you're making big decisions about who's involved in a tiered model at the system level, everybody who's involved in that system has a say, right? And you all talk about it together. So there's a lot of ways to ensure empowerment, voice, and choice. And of course, we talked a bit, and I started by talking about cultural, historical, and gender issues. And I think, again, all of the principles that we've considered here have to be made through the lens of awareness of working past stereotypes, biases, and making our services more inclusive. So if we think about that, and we can then use those principles to start building more tiered kinds of models, right? And tiered kinds of systems that help provide care across the entire continuum of services for trauma-exposed youth and families, right? What do we start to look for that tells us that someone who's experienced a traumatic event may be more appropriate for intensive kinds of services, right? So those services that would be reserved at the very top of the pyramid. Often these are like treatments for things like PTSD, right? Which is a specific condition that can result in folks who've experienced psychological trauma in some ways. So if we go to the next slide, we're going to just kind of go through some things that you might look for that often many kids who benefit from trauma-focused treatments will be experiencing. So common trauma reactions that kids who are going to benefit from trauma-focused interventions and treatments, right? Often that tier 3, the top of the pyramid kind of services, are going to involve a number of different trauma-specific kinds of reactions like re-experiencing symptoms. And again, for those of you who've already had some training in this or were at some of our echoes last year, you might remember some of this conversation, right? But re-experiencing, we're really talking about reliving an event over and over again in thought or in play. With really young kids, you might see them acting out through play certain kinds of things that they lived through that reminded them of the event. Nightmares and sleep problems are not at all uncommon, but becoming very upset when something causes memories of the event, right? It could be a song, it could be something that's talked about in class if a teacher is reading a book and it's something that reminds you of an event in some way, right? Some connection there. Any number of environmental cues can cause us to become very upset when reminded about specific traumas that we've gone through. And that's certainly the case when we think about kiddos who have more chronic kinds of unresolved trauma reactions like PTSD. Lack of positive emotions, right? We see that oftentimes folks who have more severe and ongoing trauma reactions, right, long-term, may end up noticing that they have a harder time experiencing feelings like joy or happiness or love in the same way that they did before those kinds of traumatic experiences happened. But they may experience very frequent and ongoing intense fear or sadness, right? So there's a lot more just pronounced kind of negative affect than you would see positive affect, especially in chronic kinds of trauma reactions like post-traumatic stress disorder. Irritability and anger outbursts are also very common, right? Constantly looking for threats, feeling easily startled, right? So you hear something and you may suddenly sort of jump, or you may feel really shaky, right? And you might feel really jumpy. And that can often just lead folks to feeling really, really keyed up, right? And when you feel that keyed up by things that remind you of what happened, it's not at all uncommon that you'll want to avoid places or people, right? Or activities associated with the event, or activities that you think might expose you to things that are going to remind you to what you went through. So those four kinds of experiences all together, right? The reenactment or the re-experiencing imagery, avoidance, kind of the negative emotions, negative affect, and then the feeling really aroused and kind of startled, right, are all really common trauma reactions for kiddos who go on to meet criteria for post-traumatic stress disorder or PTSD, and the ones who are often going to really be appropriate for our tier 3 services like TF-CBT, which we're going to be talking about off and on throughout the ECHO series. But I think it's important to just be aware of these different reactions. I want to also just mention that these reactions, depending on how recent a trauma was, might actually be very adaptive and very appropriate, right? Most folks are going to have these kinds of experiences to some degree. But oftentimes the nature, intensity, and frequency of those experiences will change. And if folks continue to sort of experience them, all of these different kinds of reactions in the same way at the same intensity after a period of about 1 month, you can technically meet criteria for PTSD. When we look at studies that look at rates of PTSD in children, adolescents, and teens, right, we see that generally speaking, evidence suggests that somewhere around maybe 5 to, I think, 16% of girls will experience PTSD as children or teens, and then somewhere around 1 to 5% of boys will meet criteria for PTSD. So I think those are just some things to be mindful of when we think about the prevalence of all this. Certainly trauma exposure is much more common than that, but that gives you an idea of sort of just the prevalence of the mental health toll, right? At least in the form of post-traumatic stress disorder. That might affect some of the young people that you see. But I think it's important to just note and be aware of some of these reactions, because a lot of times, especially in school systems where these tiered models have historically not been implemented, right? You might have noticed somebody in the classroom having trouble concentrating. You might have noticed that they seemed really distractible, or they just seemed really kind of fidgety and they seemed really tense, right? And sometimes kids might be mistaken as having, for example, developmental conditions like ADHD or something else, right? And they're sort of just, they might be flagged inappropriately for something, when in reality, these are trauma reactions and we don't always know what to look for, right? So I think that by recognizing and starting to have these discussions and think about how we can look for and best support kiddos with these kinds of experiences, right, we're really starting to, I think, do our part to make more responsive systems, right, where we can start to actually address historical barriers to care and really start expanding it to folks in much more equitable ways. So with that, I'm not sure who's up next. We have Aaron. So Dr. Hamburg is going to take back over here. And again, just feel free to jump in and ask questions as we go here, everybody. And hopefully this gives us a good place to continue the discussions for the remainder of our time today with sort of some common definitions in mind.
Thank you. And thank you to everyone who's been weighing in on the chat. If you haven't seen the chat that we have going on, I would encourage you to go in there, because you might see that your colleagues are seeing a lot of trauma responses that are similar to the ones that you see. And trauma can look like a lot of different things, and it can look like one thing one day and another thing another day. So we've done a lot of talking so far. And so we're going to do our second chair yoga experience. Then we'll do a little bit more didactic talk about referral processes that will prepare us for our breakout room activity. So again, kind of find that what we call yoga seat, whatever seat was feeling comfortable for you. Legs crossed, legs, both feet on the floor, whatever works best. And take a couple of breaths just to settle body and mind. If you feel calmer with eyes closed, I invite you to do that. We also know that for some people that can actually increase stress to sit with eyes closed. So make a choice that feels good for you. And now bring your palms together and begin to rub them vigorously. And continue to rub faster and faster until your hands begin to feel a little bit warm. And then slowly stop rubbing, but keep your palms together. And imagine that between your hands is a very tiny, but bright and strong ball of light and energy. And as you take a breath in, very slowly separate your hands and imagine that ball of light growing and expanding, filling your hands with energy. And when you're ready to breathe out, gently and slowly push your hands back together, squeezing that ball of light until it gets very small. Take about 3 breaths in that same manner, expanding energy and then bringing it back down, keeping the rest of your body as still as you can. And now take a moment to do another energy level check-in. What is your energy level right now? And what does your body feel like at this level of energy? And if you'd like, you can place into the chat what you felt in your hands or maybe in your mind as a part of engaging in this practice. This practice is a practice that can be good for bringing focus. So I think a lot of times people who have been exposed to traumas may struggle with focus, like Dr. Williams was talking about. And we tell people to focus, 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 but we don't tell them how. And sometimes these types of transition activities can actually bring a focus in a different way than an instruction to focus can. And in fact, some of you may notice that you feel a little more focused or a little more in tune than you did before engaging in that practice. So again, just some ideas about when and how you might use a strategy like this. Maybe by session 3, people will be ready to share their ideas in here. And I just want to mention, I noted to some of you that I had just completed actually a certification in yoga and mindfulness-based strategies for schools. And I wanted to provide you with a link to some free resources made available through the Kansas State Department of Education Technical Assistance Network, TASN. Some of you might be familiar with that acronym. But check out those resources if you're interested in learning some of these strategies so that you can implement them yourselves. These strategies are great across any of the tiers. You can use them universally throughout a classroom. You can use them on yourselves to be better prepared to enter your workspace. You can also do some cool groups at tier 2 and refer back to these strategies when children have maybe gotten to a point where they're ready to receive tier 3 services and supports. Next slide, please. So referral strategies. We have talked about why a multi-tier system of support is an important framework. We've talked about some characteristics or behaviors or emotional states that might exist in children who might be needing more intensive services and supports. And so now we kind of want to talk about how do we go about linking to available services in a trauma-informed manner when thinking through that lens of trauma-informed care that Dr. Williams described for us. So who needs a referral? Well, Dr. Williams just described a lot of signs and symptoms that children and youth might be struggling with, kind of the after effects of trauma experiences, either single incident or chronic. Well, for starters, people who need referrals are people who ask for them. Just like we talked about in the definition of trauma, that it's really hard to define what is traumatic for someone else. The person who's experienced an event is the best person to say whether or not that event was traumatic. And so we never want to be kind of judging who may be in need of services, such that when people are requesting higher level of services, we are not responding to that. So we always want to respond when people are seeking supports, especially because, you know, if you're working in a school setting or even a mental health setting, sometimes you don't see behaviors, but we have to rely on people's self-report of need. You know, typically tier 3 services are best at supporting people with significant trauma-related symptoms that have persisted for more than a month. We know that it's very normative to have disruptions in our mood, in our functioning, and in our behavior for about a month following trauma. But then when it continues, that can be a really good sign that more intensive services are warranted. However, we can provide tier 3 services to people with extreme trauma-related symptoms, even in the early aftermath. So we never want to say, oh, it's only been 2 weeks and, you know, it doesn't matter that you're driving 90 miles per hour every night while binge drinking, right? That does matter, even if the event just happened a week ago. So we don't want to be too didactic with this month. People who show marked shifts in behaviors, affect, so kind of how their mood is presenting to you or functioning. And people who are struggling to achieve learning targets despite attempted supports, which is just kind of another specific example of, you know, kind of a functional problem, problems with functioning in the real world. And additionally, remember that these tier 1 and tier 2 strategies remain appropriate even when someone has reached a level where we think that tier 3 supports are also required. Next slide, please. So how do we make referrals? Well, if we put on that hat of thinking through, that lens of thinking through principles of trauma-informed care, one thing that's really, really important to me is that we be very transparent, that we're never making referrals for random things behind people's backs, that we're being very open and honest with people, children included, about what we're noticing, what it makes us wonder, and how we can help connect them with something that at least we think could be useful. And this process of being transparent and not doing it behind people's backs and engaging their thoughts and their voice in this process early is trauma informed. And it is a way that we can help move beyond our biases, for example, because we may suggest to someone that we're wondering if a certain type of support would be useful, only to be met with a lot of confusion or some sort of explanation that helps us see their behaviors very differently. And so we always want to be doing this in conversation and collaboratively. Many of you, just given the type of work that you do, might be like, well, gosh, I can't be making these linkages and these connections. That falls really outside of my workflow, really far outside of my scope of work. But one thing that I will say is, if you are the person who has really identified that a child might be in need of a higher level of support, I think that it's very trauma informed for you to really be highly involved in that kind of baton passing. It's very trauma informed to make sure that if we think someone could use a higher level of support, that we see that process through start to finish as best we can, right? So if we're going to delegate a job to someone else or go find someone who we think is better equipped to make a referral or to work with a family through that process, we also want to be going back and closing the loop. You know, did that happen? Is the person that you handed that off to, do they have the capacity to do that right now? And if not, how can we get this into the hands of somebody who can? Maybe this is the type of situation where you really are the right person to help a child or a family think through the types of supports and services that might be available to them. And I would always encourage you to do that as collaboratively as possible. Some people will say, I really want you to do this for me, to figure out what supports might be available. But other people might feel just as bewildered as you do by the variety of resources available and say, you know, I really want to do this together. Could we even call a local service provider together? Could we be on the phone at the same time? Can you tell this part of the story while I tell that part of the story? That's a very trauma-informed and collaborative and transparent way to help connect people with services. We also want to describe the process as we know it very clearly and upfront to children and families. So maybe, you know, I'm recommending that, you know, your child be assessed by our school mental health team. Here's the name of the person who's going to reach out to you. And I expect that they may be able to reach out with you to you in a couple of days. And guess what? If they don't, or if you hear from somebody different and you're not sure why they sent the email, circle back to me, right? That basic information can seem so small, but it can go so far in terms of helping people actually feel supported instead of feeling kind of farmed out into a system that just might feel overwhelming or very different to them. And also, if we're trying to connect people to systems of support and we know that a trauma history is part of the picture, we know that, you know, multi-step intensive processes can be challenging because one possible reaction to trauma is kind of a decrease in our attentional capacity. Next slide, please. Yes, I love Laurie's comment here in the chat as well. It reminds me of all the stuff we talked about last summer in our psychological first aid trainings. Start with the basics. We have to be mindful when we interact with people. We can't be thinking too far down the road such that we're not paying attention to the basic things that could be addressed right now. So on this slide, I've kind of put these ideas into two different columns. One is referral strategy ideas. What can you do personally? Maybe if you're a person who has time to help connect children and families, but also what can the system do? Because our systems have a role in terms of ensuring that we have processes to help make sure that people in need of referrals don't get missed, that baton does not get dropped. If you work in a school system or a community mental health center or another place that provides services, first think internally. What resources do we have here? You know, have I been to any trainings lately where I've met somebody who's involved with mental health provision? Maybe I could ask them questions. Thinking through, you know, would some sort of assessment help with this process? Or do we maybe need to be thinking, yep, let's go straight to an intervention? Does this child have a 504 plan or an IEP in place that we could reference and see what supports are already being provided? And if they don't, should we be thinking about putting in a request? Should we go and find the pathways to put in a request for that? In terms of external referrals, you know, a couple good places to start. You know, sometimes those of us who don't feel very well prepared to be providing referrals, I don't want to say get stuck with that job, but find ourselves in situations where we're the best person to provide that support. So I'd encourage you to take a look at this link to local community mental health centers in Kansas. It's a comprehensive list. If they can't provide the services, they might have somebody there who is like a mental health navigator or something like that who could assist walking the family through the process. I even, as a clinical child psychologist, when people ask me for referrals, I go to this Psychology Today Find a Therapist website all the time. It lets you check things like the type of insurance the family has, if there's a specific gender of therapist that they are preferring. So those are just some initial places that you can go and help the family to go. And what can the system do? There are so many good resources available for schools and other organizations that are looking to be better at identification and linkage to referrals. So develop referral pathways for mental health supports. Does your organization have a referral pathway, an existing one? There might be one that exists that you've just never needed to access, or maybe one needs to be built. Lots of schools, for example, are building leadership teams that are tasked with developing these referral pathways and making sure that throughout these tiers of support, children are receiving what they need. And some schools are even moving a step further and building district community leadership teams where higher ups from the schools and local community mental health centers and local juvenile justice and local foster care agencies are all sitting on the same committee where they're talking about the children and families who cross their different locations and saying, how do we develop intervention goals that are the same across all of these settings instead of having very different goals in the different settings that sometimes can be incompatible with one another and further confuse and cause problems. Next slide, please. There are lots of different available service types, and I know I need to speed up here so we can do our breakout rooms, but typically these outpatient services are probably the type of services that you're looking for, these weekly types of services, but you know, Melissa mentioned tier 4 and tier 5, and some of these more intensive services are definitely available. And so just broadening your horizon about what's available can help you be a really good referral provider. Next slide. So what we're going to do now is talk through a scenario related to how to respond and what to do if a child that you are in proximity to discloses trauma. So regardless of your role or scope of work, for right now, we want you to put on the hat of I'm the person who a child has chosen to speak with about something challenging. So next slide, please. So when you get into your breakout room, you're going to be working with this scenario. You're on the playground and an 8-year-old child is telling you about their summer. And in the midst of the conversation, they say that something very scary and bad happened to them this summer. How do you respond? So in a minute, when you get your breakout room invitation, you're going to be thinking through this scenario using the lens of those trauma-informed care principles that Dr. Williams introduced us to. If anybody has any questions or follow-ups based on the breakout room experience, feel free to pop those into the chat here. We won't have time to answer them today necessarily, but could answer them for you at another time, make sure we address them in the next session, that sort of thing. So I realize lots of you are just coming back, and I was saying if people have follow-up questions or concerns or ideas based on that activity, then please place them in the chat, and we will make sure that we get to them. I know we only have 3 minutes left today, but we have 2 more sessions, so we can get to it. What about my breakout room leaders? Anything that we really need to make sure we wrap up about that exercise as a larger group?
Erin, this is Melissa. And I think one of the, yay for group 2, always a great group. And also one of the things that we talked about kind of across the specific question I posted in the chat, but also just generally speaking, is kind of how to navigate these different principles when they seem to contradict each other. So we want to create space for young people to share their feelings and to tell us more, right? Before we kind of jump to conclusions, but also we want to be transparent and honest about who we are and what we're doing there. And so kind of when is the right time to disclose, like that we're mandated reporters, for example, and like kind of how do you balance that? Someone starts disclosing something and talking about it, and then kind of how do you handle that? And I think there's a whole bunch of different examples here. How do we empower young people, but also acknowledge they're existing in a system where they don't necessarily have they don't have power and control and choices sometimes, right? So how do we do both? And kind of when these different principles kind of interact.
I love that. I think that'll be a great place for us to start our conversation next week, as we're kind of talking about trauma-informed approaches more broadly. So yeah, thanks for bringing that. Next slide. So we don't really have time for Q&A today, although we are available. Send us a message, shoot us an email. But if you want to just end up today by placing any new insight that you may have gained today into the chat, that would be great. A word that comes to mind, or a strategy, or just something that you're centering your thoughts around. Next slide, please. And please join us next week. We have 2 more of these sessions. They will build on each other, but if you have colleagues that couldn't come today, please let them know that I don't think they'll be too lost if they join us next week. And again, thank you so much for spending your afternoon with us, and we look forward to seeing you next week.